Okay, we are live. Start.
Yeah. Hi everyone. Today's topic for discussion is thin endometrium. I know sir has become very thin these days, and he wanted to speak on thin endometrium just to pick up the word thin. So he has lost a couple of kilos and looking very nice and very fit, thanks to whatever diet he's following. So, but I think human beings look good thin, but the endometrium is not very good when it is thin, and all IVF consultants get very nervous and very stressed when they see a thin endometrium, and it's a very frustrating condition in any of the IUI or even in IVF cycles. So today, I think Sir will give an insight as to how to evaluate, and I think it is difficult to cover this thin endometrium topic in just one session, so we will divide it into two sessions. So today's session will be how to evaluate the thin endometrium. So over to you, sir. You can take it forward from here.
Yeah. So I'll go to the screen sharing. See, we'll have two sessions. Probably one is just evaluation, and the second session is going to be on management. Okay, of thin endometrium. So I guess Shilpa madam, you can see the screen, right?
Yeah, yeah, yeah.
Okay, fine. So I think see what is probably very important for people to understand as far as thin endometrium is concerned is is first understand what goes really wrong when you think of a thin endometrium. So if I try and draw the uterus, okay, thin endometrium is something which even at its peak is not able to usually cross a thickness of more than 5 millimeter as per the standard definition. Okay, but if you look at our target thickness, which we want to achieve in an IVF cycle, okay, our target thickness is going to be between 7 to 9 millimeter. Okay, so this is our target. It's important to understand the endometrium again from the endocrinological perspective in correlation to the ovary, because everything is then correlated with the oocyte which is actually present inside this ovary. So as the ovary goes from the selection of the antral follicles to the phase where there is a single dominant follicle which is secreted, to the phase where this dominant follicle then grows in size nicely until the phase that it actually becomes a large follicle, pre-ovulatory follicle. Okay, and then once it gets converted into a corpus luteum post ovulation. Okay, all these phases are very, very important for the particular endometrium, because all this is related to the way in which estrogen goes up. So it is somewhere around here where, apart from the basal estrogen, so everybody has a basal E2, and I will come to basal estrogen, which is important. From the basal estrogen, there starts a good secretion of the estrogen, where the estrogen would usually be in the range of 50 to 100 at this phase. From this phase, this estrogen would move and would try to reach a peak of around 200 to 300. Okay. And then from there, just about pre-ovulatory, it will be somewhere again between 150 to 200, because that is important for the LH surge to occur. So, what is very important for us to understand as a part of understanding the endometrium is that the word basal estrogen. Okay. So, if I micromanage this endometrium and enlarge it, okay, I will have something like this. All right. I will have a basal layer. Okay. I will have a basal layer like this. Beyond the basal layer is going to be the myometrium. So, I'll just draw the myometrium so that we understand it. I'm drawing it in brown color. Okay, this is very, very important for us to understand. Through the basal layer, you have, these developing arterioles. So in the early phase, they are very straight. As the menstruation, as you come close towards the phase at around 200 to 300, it starts getting convoluted. Then at the time of ovulation, there is some more amount of convolution. Okay, this is something which we need to understand. And this endometrium, so if I just draw this endometrium, let's assume this endometrium is something like this. then this endometrium starts developing these fronds, okay, at approximately this stage. And these fronds then keep on growing through the secretory phase and develop secretions inside them. Okay, so what is categorical for us to know is that in the basal endometrium, basically these blood vessels are first going to be present. Okay, so this particular part, no, which is called as the basal endometrium, apart from having the blood vessels, it also contains stem cells. Okay, it also contains these stem cells which allow proliferation of the endometrium to occur. Okay, and what is important is all this. Okay, basal endometrium as well as stem cells are dependent on estrogen. Now, this is something which you need to take home, because when you understand this concept, you will understand the concept of giving priming. Okay, you have a concept of priming for postmenopause. Okay, why do you need to give priming for postmenopausal uterus? Is because there is no basal E2. Only once you have a basal E2, you will be able to prime a postmenopausal uterus. Okay, or simultaneously a uterus of an ovarian failure. Okay, or simultaneously a uterus which is small in size. Okay, all this is going to require a good amount of basal estrogen. So keep that concept in mind. And the other concept which you should get introduced is that your functional layer is basically divided into a compact, so it's called as a compactum and a spongiosum. Okay. Just remember one thing. The implantation which is going to occur somewhere here. Okay. So the implantation usually occurs in the layer of compactum. So just keep that in mind as a part of your understanding of reference when it comes to development of endometrium. Okay, so when we try to study this, now when we try to study thin endometrium, it is important for us to understand that when we talk of thin endometrium, the causes, what we have to keep in mind to evaluate the thin endometrium is very simple. Don't get into all the theoretical causes of evaluation. Okay, so first just try and evaluate the ovarian causes. Okay, is the ovary functioning normally? In the ovarian causes, obviously, you have one of the most important cause, that is ovarian failure, low AMH, poor oocytes. Okay, you have these things, and these are your most important things which you need to keep in mind as far as the ovarian causes are concerned. It's very simple, no, if you divide it this way. The second are going to be de novo endometrial causes. That means for a particular lady, okay, let's say 5 millimeter is considered to be a normal endometrium, but we are calling it thin. Okay, that means the endometrium itself, God has gifted this uterus with an endometrium itself to develop only this much. All right, or or this is just one thing. I mean, when I talk at de novo endometrial causes, one is something which is physiological for that lady. Second, you need to keep in mind is any Mullerian problem. Now, this Mullerian problem can be a rudimentary hole, infantile uterus, small uterus, this, that, 100 other things. Okay, and the third is all external causes. So, what are the most common external causes which we need to study or we need to keep in mind, which can affect every other thing? Okay, which can affect the situation of the basal endometrium. So, the first thing is infections. Okay, in India, especially infections. So, what we commonly call as endometritis. Okay, now in India, you have to keep in mind about TB. There is no second thought about that. Okay, the second is injury. So what can be the cause of injury? Again, common. I have this habit of writing radiation first because I see a lot of them. Much more common is a DNC. Much more common is a hysteroscopic procedure. Okay, these days. Okay, so just keep in mind whenever you have exposure of this basal endometrium in the form of one condition where we want to create this injury, okay, is a surgery called TCRE, transcervical resection of the endometrium, where if you study the histopathology, okay, the histopathology says myometrium seen. Okay, so basically in your TCRE you are trying to knock out the entire basal endometrium right from here. Okay, right from here, and you don't want this endometrium to regenerate so the patient doesn't get into menses. So just keep this thing in mind. Okay, anything which causes a basal endometrial damage, especially infections, especially TB, because TB causes basal endometrium to undergo fibrosis, as a result of which it is very difficult to regenerate this endometrium, and as a result of which the stem cells, when isolated correctly, will go and work because you are putting stem cells right inside the basal endometrium. One of the things where we commonly keep on joking is that PRP will not work in such type of situations. Though we all love PRP, is because PRP is just activated platelets. So what does your activated platelets do? Just a simple concept, okay, which people should understand. I'm just deviating for a minute. These activated platelets are all actually going to cause effect here on the compactum. For an activated platelet to work, you need a good compact layer, because only after that it can secrete factors which can increase the vascularity. Okay, it cannot go in the basal endometrium and work, as a result of which PRP is slowly and slowly getting outdated as far as the true external causes of endometrium are concerned. As a result of this, you can put this PRP slightly in that basal endometrium. We think that we are putting it here. It's actually going and spilling inside the compactum layer, and when it goes and spills inside the compactor layer, it tries and gives the desired effect which it should give. Okay. Now, keeping all these things in mind, let's just try and understand, okay, what we need to do mentally whenever, after I give this block, that okay, this is what is the thin endometrium. So mentally, what do we need to do when we see a patient of a thin endometrium? Okay. So first, this is just a flowchart which we have in the hospital. So I'll just share it with all of you. Once we have done an ultrasound, when should you do this ultrasound? Ideal time of doing the ultrasound is after HRT for at least 10 days, or when you are doing modified natural cycle in the presence of a dominant follicle. Okay. And in all of this, if the endometrial thickness is persistently going to be less than 5 millimeter, okay, on your ultrasound, the other thing which may just add some value is fluid in the endometrial cavity. Okay, so when I draw the uterus, this uterus at the peak is having an endometrial thickness of less than 5 millimeter. Now remember one thing, it can be 4 millimeter with a triple line. Okay, it can be 4 millimeter with a triple line, which is also thin endometrium. It can be a 3 millimeter and no proper appearance. Okay, so you just see a thin stripe. All of that is thin endometrium. Okay, just keep that in. After you have seen this ultrasound, very, very important is what at least we do, and this can be followed as an absolutely standard protocol. Okay, is to do an office hysteroscopy. Okay, now office hysteroscopy is something which is magnificent as far as thin endometrium is concerned. Your office hysteroscopy is going to help you pick up very, very important signs of endometritis. Okay, especially chronic endometritis. It will help you pick up Asherman. So we should not call it Asherman. We should just say intrauterine synechia. That is a very, very common thing, which is the other most common thing for causing thin endometrium. Okay, but endometritis much more common because endometritis is treatable. These things have a typical appearance as far as the endometrium is concerned. So just keep that in mind, and just keep in mind other uterine anomalies. So sometimes it could just be a basal endometrial damage. Endometritis, as we have said, it's very simple. You need to give antibiotics, okay, or you need to do an culture. Asherman is just you need to do a synostolysis, okay, and anomalies you need to treat accordingly. But in both these situations, you will have a great advantage of putting stem cells. So we'll come to this exact stem cells and the technique in the next session, because when we are going to discuss that, the third thing, after, there will be some people who will say that I don't have the facility to do an office hysteroscopy. What next? Okay, so this is just an adjunct which people should remember. If your first cycle has been tried with an HRT, your next cycle should be a modified natural cycle. And if in HRT cycle as well as modified natural cycle, you have this problem where the endometrium is staying thin, okay, then you can switch to a office hysteroscopy. Okay, otherwise, if you have the facility available with you, it is best and absolute best to do an office hysteroscopy on an immediate basis. All right. Now, with this spoken and this much amount of theory explained, I'm concluding the presentation here as far as basic understanding and flowchart of evaluation for thin endometrium is concerned. One really need not get into any further details beyond this as far as evaluation is concerned. Just keep these 3 points in your head. You see a thin endometrium on HRT, next cycle should be modified natural cycle. You see a thin endometrium on stimulation, on your letrozole stimulation, or your on your clomiphene citrate stimulation. Remember, if it is a persistently thin endometrium, okay, after ruling out problems in egg quality, okay, after you have ruled out problems in egg quality, okay, so I'm not saying you should ignore that, but after you have ruled it out, do not try to stretch it. This should be the approach of choice, which will give you answers to more than 90% of your questions. Okay, with this, I conclude the evaluation. The exact discussion on management will be taken as a part of the second session. Okay, so Shilpa madam, probably if you have questions, you can go ahead and ask them.
Yeah, do you divide the evaluation based on the thickness, like say 3 to 5 mm and for 5 to 6 mm, something like that?
Yeah. See, this is a very practical point which I wanted to tell you. If the thickness is above 5 millimeter but less than 7 millimeter, okay, if the thickness is above 5 but less than 7, it's going to be 80% of the times an ovarian cause. It's going to be a cause which is related to the oocyte, okay, because that indicates that usually the stratum compactum has formed, the stratum spongiosum above that has not formed. Just keep that practical thing in mind. If the endometrium is persistently less than 5, it is almost always an endometrial cause.
Okay. So, in such situations, like what do you do? I mean, if it is 5 to 7 mm, you stimulate again with a different protocol and then make
Modified
sure that the
on
oocyte is.
Honestly, madam, the modified natural cycle stimulation with letrozole is going to become your treatment of choice to verify it. If despite that, let's say it is staying 5 millimeter, okay, just switch to an office hysteroscopy. Simplest of the explanations. There should not be any confusion on this thing. Should you do a further ultrasound to evaluate? Should you do a 3D ultrasound? All these types of things don't really matter in these type of situations. If you want to concise it and give one solution to the patient on this day, do an office hysteroscopy.
Okay. So, do you measure the basal E2 levels in all cases of thin endometrium?
It's good to measure, but it's very important to remember that apart from ovarian causes, that is apart from cases of ovarian failure, all right, the basal E2 will be absolutely normal.
Yeah.
Okay. Only in cases of ovarian failure, you will have basal estrogen less than 15. Okay. Or typically less than 10. Okay. In that type of situation, you are 100% sure. The minute you add estrogen, remember one thing. Even if the ovaries have failed, basal E2 will not be zero. That is because body has peripheral fat and peripheral fat is going to secrete some estrogen. But that estrogen is not enough or not potent enough to go and stimulate that endometrium. Okay. In fact, that is the cause of having postmenopausal bleeding, right? It is the peripheral estrogen despite having a non-functional ovary. So that means the ideally the basal E2 is less than 10. But the amount of peripheral E2 due to obesity is so high that it has gone and acted on that uterus in a continuous manner without progesterone. Okay. It has just caused the arterioles to get spiraled so much that it has ultimately given rise to cancer, which is what you are seeing in office hysteroscopy. Again, that appearance is what you see in office hysteroscopy. Okay. So just keep that thing in mind. It will help you in identifying the causes.
Okay, to extrapolate what you just said, so if we downregulate, see if there is excessive downregulation where the E2 goes less than 10 in on day 2. So do you think
Yeah.
the same scenario is likely if we stimulate with HRT?
If you are stimulating with HRT, the thing with estrogen, I mean estradiol valerate or estradiol hemihydrate is, madam, on the first tablet itself, which you give. okay, the serum estrogen levels which the patient has with a single tablet will exceed 50 picograms. Okay, so if you give this dose continuously for let's say 7 days of exposure, madam, it is a supraphysiological exposure of estrogen. As a result of which HRT cycles, because of this persistent supraphysiological exposure, okay, as a result of which the world is trying to shift into modified natural cycles because it is more natural, so it has a slightly better window of implantation.
Okay, so I have seen in your files and case papers that you don't cross beyond 6 milligrams of estradiol hemihydrate, mostly, whatever I have seen, that's all.
98%, yeah, yeah.
So, is there any situation where, in cases of thin endometrium, do you go overboard and give 12 mg or 10 mg?
No, madam. Actually, try and understand it this way. When you have a patient with ovarian failure and you are giving her HRTs to menstruate, how much is the maximum dose of estrogen you give? 4 milligrams, right? You give one tablet in the morning, one tablet in the evening. That is enough to generate an endometrium thickness of 12 millimeters for that lady. Understanding? The concept is very simple. This dose, this oral tablet which we are giving, okay, 2 milligram is a supraphysiological dose already. Okay, the human body does not have that many receptors. As a result of which, it is written even on that single tablet. When you have even 1 milligram packing, no, of the hemihydrate or the tablets which is available, it is written on that that even the first tablet can cause the patient to go into a thromboembolic episode because it is a highly supraphysiological dose already. Okay, so when people say that they gave, let's say, 4 tablets, or let's say they gave 6 tablets and they got excellent results, that is itself weird because such a high dose of estrogen, if you pump inside the patient, you have a huge thromboembolic risk without having any added benefit on the endometrium because the number of receptors will get loaded in the first tablet itself.
Mhm. Okay. So tell me this. I mean, you mentioned about chronic.
Sorry, I'll add something. I'm so sorry. I'll add something. We don't give double dose in bicornuate uterus, nor do we give a double dose in didelphys uterus, madam. In that situation, also with the same dose, the endometrium develops equally well in both the uterus. Correct?
Yeah, yeah, yeah.
Which indicates that the tablet is already supraphysiological. So keep that in mind.
Oh, that's very good point what you mentioned. Okay, so tell me, you were discussing about chronic endometritis and thin
Yeah.
endometrium. So after the course of antibiotics, say doxycycline, cynomycin, whatever we use, do you think that the
Ideally, you should wait for 2 months after that because what will happen is once you give the dose of antibiotics, okay, this antibiotics will first take care of the bacterial load or whatever. And once it takes care of the bacterial load, after that, there is a flare reaction which occurs in the endometrium. This flare reaction for the first cycle is going to give rise to a white endometrium. By a white, it is a little whitish endometrium, predominantly because of the inflammation which is present inside. Okay. After that, endometriums get shed off. Okay. Then the endometrium which develops after that will usually have an excellent appearance. So usually you can give it a 40 to 60-day cycle for it to develop nicely.
Okay, that was not my question. The question was, I mean, post antibiotic usage, do you see that the
Yeah.
thickness will improve or it is only the quality that improves? I mean, the thickness remains the same or the
If the
thickness also
bacterial load, if the bacterial load has not caused any damage to the basal endometrium, then the thickness and ecotexture will both improve. If there is some damage to the basal endometrium, thickness cannot improve, ecotexture may improve.
Okay. So tell me, I mean, between say like you have an endometrium of 7 millimeter, which is say grade C, but you have an endometrium of 6.5 millimeters, which is grade A. So among these, I mean, what do you think? I mean, which one is better?
First, one must understand that even if you have a 5 millimeter endometrium, forget 6, madam. Even if you have a 5 millimeter endometrium, this endometrium alone has got nothing to do with IVF success rates. It is the euploid embryo which is generated by the body with a good oocyte. Okay, that euploid end embryo itself has a great role in synchronizing the implantation with the endometrium. Okay. So if you are putting in euploid embryo on a 5.5 millimeter endometrium, let's assume that, okay, and if it is able to have a good endometrium relation with the embryo, it will implant and give rise to a healthy pregnancy, as against an aneuploid embryo over an 8 millimeter endometrium.
No, no. So you mean to say that the endometrium doesn't have any role at all in implantation? The
It
thickness
is
of the
the
endometrium doesn't.
It has, of course, it has a role, madam. But what I wanted to answer that question on grade A and grade C. Okay, so it is more dependent on the euploid embryo, how that euploid embryo goes and interacts with that endometrium.
Yeah, that is accepted. See, forget about the embryo part. I'm just talking about the endometrium. So you think that grading of the endometrium is a waste of time and we should just stick to only thickness and forget about the grading? Is that what you mean?
So for practical purposes, we should look at the thickness. We should try and look at the vascularity at a PRF of less than 0.3. Okay. And we should look at the eco texture. These three things. But if in case you try to judge everything by grade A, grade B, grade C, score 5, 4, 3, 2, 1, as far as vascularity is concerned, the probability that you will hit the jackpot in almost all cases is going to be less. Your cycle cancellation rates will go up.
What do you mean by eco texture then? If it is not grade A, grade B, grade C, what is your concept of eco texture?
I can show images which I'm going to show in the next class, okay, on how the eco texture will improve. But I can tell you one thing very simply for a very simple explanation. Okay, we call a good triple line a good triple line, right? This triple line we call good, especially when there is no progesterone exposure. That means when progesterone is less than 1.5 or 1.2, whatever is the cutoff which we follow, and we
Mhm.
see hyperechoic lines as three hyperechoic lines, and we see an absolute, mild hypoechoic area in between. It is not a black area, it is mildly hypoechoic. Simultaneously, if you zoom in, okay, you will have hypoechoic areas beyond that triple lines also. Okay.
Mm.
Okay, so that's that typical 5 zone appearance which people try to speak of. Okay,
Mm.
if you get into a habit of looking at this 100 times, you will automatically, your mind will start telling you like an AI algorithm that this is a good eco texture, this is a bad eco texture. Okay. I practically only look at that. I only look at that. I don't look into it from any other angle. I look at that endometrial thickness, typically more than 6.5 millimeters. We are a good to go for transfer. Okay.
Okay, what is your thought process on endometrial volume?
Good. But again, one must understand that endometrial volume is a thing which somebody has to be good to measure. That is the first thing. You can't really start extrapolating saying that a Samsung Hera W9 and a Volution, let's say P8, okay, or an S2 will give you the same outcomes for an endometrium volume. That is one. Second, the volume of endometrium is operator dependent. You might be excellent, I might be excellent, but probably Visma is better than both of us. So he might add that 1 cc into that endometrial volume because he will take that perfect cornwall stripe, madam. That is the disadvantage when somebody like me, normal guy, would do it, right? We may miss out on that little cornwall stripe in mapping that endometrium before we take the volume. Okay, these guys who are in love with ultrasound, no, they will go to that cornu, they will draw the cornu nicely and then measure the volume. So there could be observer variations. Okay, so keep that in mind.
Okay, what do you think about the age as say you told about the ovarian failure cases or menopausal cases where you're trying to stimulate the endometrium for probably a donor oocyte or something. But what is your thought process on age as a factor? See, if you have a 28-year-old for an IVF with blocked tubes with poor AMH and obviously low result compared to a 37-year-old lady with a say normal oocytes. So who do you think, I mean, is more tendency to have a thin endometrium?
No, uh, I don't think it is going to be just dependent on these many variables. But I can tell you that that this 28-year-old girl, if you put in a euploid embryo, again I'm stressing on that word euploid because the concept of endometrial receptivity is continuously getting linked across the world to the embryo. Okay, so if you put a euploid embryo in both these uteruses, 27 versus 37, the implantation is higher in 27, irrespective of other factors.
Yeah, I think we'll stop here today. We'll take up the next line of questions about treatment and controversies in the treatment after you finish your presentation on management.
Okay, no problem.